Thank you. Sorry about that. I was asked yesterday to step in for Christos, and I have to say I have a complete absence of information specific to the body and tail of the pancreas, and in fact I'm unaware of any significant trials in this area. So I will stick to the evidence from randomised trials and which information I do have from pancreas head cancer, so I apologise for the difference. I'll start with the summary of some guidelines that were published last year, and you can all read those, but patients who have undergone surgical resection for localised pancreas cancer should receive adjuvant therapy. There is no single adjuvant regimen that could be considered as superior, and the role of radiation as a component of adjuvant therapy remains controversial. So let's just look at some of the evidence that has led to this consensus statement. We're all familiar with the results of the SPAC1 trial, at that time the largest randomised study in adjuvant therapy, and this just shows here one of the survival curves indicating a clear benefit for adjuvant chemotherapy, 5-FU-based chemotherapy post-resection. And when a further analysis was done, including patients from the first phase of the SPAC3 trial, the same result. And this is SPAC1 just looking at different stratifications, that the advantage for chemotherapy held true in all groups except for the small size lesions, and that may have been an issue of numbers, but it did not hold true for resection margin status. And patients with positive resection margins did not seem to benefit from the chemotherapy, and I will enlarge on this a little later in the talk. But certainly patients with negative margins did benefit significantly from the chemotherapy.